to start off today is burst that bubble, because it isn't. It isn't all about patient care. It isn't now. It's never been in the past, and it never will be in the future all about patient care. What it is all about is all the patient care that we can provide on the dime that we're receiving and nothing more. Now, understanding that, even as an EMS administrator, and having said that, I haven't forgotten what our primary mission is. But let me just phrase what I just told you. No margin, no mission. So if you can't generate enough revenue to keep your organization going, then you have no mission. So the disclaimer is then, the best advice that you'll have is from your own accountant and from your own entity. But this is going to give you just kind of a brief idea of kind of how I look at things. So, and the clicker isn't going, so if you'll
Shoot, it's all her fault.
it's all her fault.
Kim, try clicking in there.
So Clem, if you'll hit,
I probably moved again, haven't
Probably.
I? Okay, so I'll come back here. Now try it.
there you go. And so, you know, it's really funny when I started trying to figure out how to do a lot of my accounting and my accounting principles and what I look at. This is a kind of a dated document. It's from 2008, and it's called EMS Structure for Quality, and it's put out by the American Ambulance Association. And if you are a member of the American Ambulance Association, you can get it for free. It's part of their online publications, but it does address a lot of things about setting up an ambulance service, funding, finance, and it actually defines an awful lot of the things that I'm going to talk about today. And it's not a complex, it's not a long, it won't take you forever to get through it, but it really will give you a good basic understanding of some of the stuff we're talking about. So let's get started. And even when you think about all the costs that are associated with running an ambulance service, I kind of refer to this as the cost equation, because the cost equation is going to get into, and the total of the cost equation is going to get to and be critical in some of the components of the calculations that I make in the future. And so the first thing you got to remember is, a lot of times you go to these presentations and here there's indirect costs and there's direct costs. Indirect costs associated, all those costs that aren't necessarily, they're related to, but not necessarily associated with the transport. But then there are your direct costs that are directly related to a transport. But we have to break them down maybe just a little bit more, and that your fixed costs are those types of costs that don't vary at all. Whether you're running one transport or you're running 100,000 transports. And when you think about it, one clear example could be your station and your station costs. You have to have a place to put whatever it is you have, ambulances, people, and stuff. You got to have that, and that doesn't necessarily relate at all to the number of transports that you run, but it is a significant cost. The next thing is your indirect costs, and those are some things that could be related to transports, and that could go into things like your legal expenses and some other costs. And then there are shared costs. How many of you are part of a hospital or part of a fire department that provide EMS? So what's interesting is that, and even as we start doing some of our cost reporting, whether it's with the SRP or we do some of our cost reporting with the Medicare cost reporting, somehow you have to account for all those costs that are associated with things you share with somebody else. And that can be your station costs, that could be your utility costs, that could be, because what we're trying to get to is how much it really costs you to provide all of your services. Now the direct costs are pretty much easy. So that's your personnel costs for your medics. I will go back and say that one of the indirect costs is your administrative staff. You have to have administrative staff to run it, but they're not directly related to the transports, but your staff are directly related. Your paramedics and your EMTs are directly related to what it is, how much it costs to run your ambulance service, your medical supplies, your medications are all part of those direct costs. And then you have marginal costs. And those are direct costs associated with one additional transport. And I think the big example that I could give regarding a marginal cost, for example, as it relates to one additional transport, when we first started, we had a hospital open up in our area. And they had interfacility transports that they wanted us to perform. And at first, there weren't that many. And so when they came to us and said, would you do our interfacility transports, that really didn't add that much more cost to our service to do that additional transport. And the other thing that those transports did is they provided revenue during a period of time when the crews would not be otherwise responding to a call. That makes sense? So that was what that additional revenue was. Now you add all of those up and you get to the full cost of running your ambulance service. And that's going to become important in just a few moments as we get into some of my other stuff. Now, I will kind of bring this up as an adaptation alert when you talk about cost creep. Cost creep in the document kind of refers to if you're a dual agency and how you're trying to not account for all those costs, like the shared costs of running an entire ambulance service. To me, cost creep and how I've adapted cost creep to what I do is some of those other costs that add up that are not reimbursable costs. With over the past couple of years, we have, because it's better for the service and it's made us more efficient, we added this program called Bamboo. And what Bamboo does is it helps us with our scheduling, it helps us with payroll, it helps us with an awful lot of things. It's a fairly significant cost, but it's a non-reimbursable cost. You start adding that to the cost of running services and it continues, your costs start sneaking up on you. The other thing that happens throughout the year, I'll be funny. I mean, it'll be funny for me, you can see how many hands go up in the room. You spend all this time writing your budget. So you really have a good idea of how much you're going to spend, right? And then your crews, your captains, a group of people come up to you and say, hey, can we get new mattresses this year? And I'm like, maybe. How come you didn't budget for new mattresses? If we needed new mattresses, how come we didn't get it? How come we didn't include them in the budget? Oh, we didn't think of that. But the mattresses are getting really, really bad. Now, all of a sudden, even when you're thinking, well, my crews aren't getting good sleep, blah, 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 blah. So you decide, okay, let's get new mattresses. And then before you know it, a $200 mattress divided by however many stations you have is a huge cost that you didn't plan on that is starting to creep up on you when you think about paying for your services throughout the year. So how do I now this isn't how do I actually account for in my finances the difference between the direct and the indirect and the fixed? So a lot of the indirect costs, those costs that are kind of related to running the ambulance services, but not directly related to providing patient care, I call them my administrative expenses. And you can see all the primary line items. And for me, this is a year-to-date comparison of what we were spending last year versus, so this would be last year, and this is what we're spending this year for this particular period of time. And this is where we put a lot of our indirect expenses because they're not directly associated with patient care. And this is where I put my direct expenses. So everything related to providing patient care is right here. Those are my direct expenses. Now there's a couple of other things that I include towards the bottom, you have debt service. Debt service is what do we pay for the station that we just bought? We include that as a separate line item. And any capital expenses that we buy, we include that on this portion of the financials as well. And anything grant related, because it's funny, and we do a little change towards the end of the year, but as we're working throughout the grant period. And that's one of the cool things about QuickBooks, is that if you get a grant in, you have to be able to tie whatever expenses that you're on and goods that you're purchasing back to that grant. Because the grant writers or the grant givers want to be able to make certain that you're spending the money on what you asked for. And so we're able to track that. Kim?
Question for you, Tim, in having reviewed many grants at the state yourself, and I'm sure other people in the room have also, some agencies will include a potential grant in their budget and some will not. Which should be done?
That's actually a great question, because what I do, for example, when I get a state grant, and I understand that for the next grant, you have to apply starting in December, is that right?
Yes.
And that the grant is generally, application is done within January sometime. You go through all the grant hearings, and you're actually awarded the grant in July.
More like September.
But at least you, well, that's when you get your contracts, right?
Yes.
So, but you see, one of the cool things about the way we do it is, even if it takes, you get the award in July, and it takes you until September to get your grant, I don't ask for that type of a grant, like the EMS grant for staff, partly because of that reason right there. I usually ask for gadgets, and widgets, and cards. That's what I ask for. So I'll find out by July what it is I was awarded or not, and I'll just include that in my following year's budget. So my income will reflect the grant dollars that I'm gonna have, and my expenses, my grant specific expenditures will reflect what I anticipate spending on that. That makes sense?
Yes.
Because I don't like budgeting for things that I know I'm not gonna get, or I may not get. Any other questions so far? Seems pretty simple, pretty clear. Now, if you've been wondering about the revenue, and one of the things that I really like about this particular side is we use this highly complex accounting software called QuickBooks 2023. And I'm a government entity, and one of the things that QuickBooks does not do is fund accounting, but it does. And it does fund accounting by, it calls them classes. And so I will we have literally set up a class called the EMS division. That's my 911 ambulance side. And even when I'm thinking of some of the fire departments out here, who run fire prevention, run EMS, you can actually set your QuickBooks up very similar to this. And you can set them up. So where I have my EMS 911 division, my community paramedic division, and my outreach education division or fund. And then I get over here kind of to what would be loosely referred to as my general fund, because you budget for monies and then you appropriate from your general fund to your individual funds, right? And the cool thing, even if this, for example, was my prevention division, I could see what I was bringing in for my inspections. I could see what kind of revenues I was generating from doing my prevention stuff. And then I could compare it to my expenses as well. So even as I break it all out, I can see whatever my expenses were, where my revenues were, and then I'll back up to my bottom line of the full cost of providing services. So that's kind of the adaptation of using QuickBooks and applying it. Now, it doesn't necessarily work cleanly. I mean, we have found a few things in QuickBooks that as I'm running my financials at the end of the month, what is it? It's like some of the retirement stuff and some of the health expenses, they always show up in this kind of unclassified category. So I have to go back and reallocate those. But that's not that hard to do. Most of the expenses do easily go into classes. And it's funny when you're thinking about the different divisions, like if I'm trying to figure out how much of my utility costs or my debt service costs go to the community paramedic program because they run out of my stations. You can either do that by figuring out the square footage of all the buildings that they actually occupy, or keep it simple. If you can think about the percentage of the call volume that they run, they're now getting up to about 20% of the volume. I can actually allocate those shared expenses by 20%. And so a lot of those other costs for the PAC division would be 20% of the total. At least it gives me an idea when I'm trying to get down to the full cost of what my community paramedic division is versus my EMS division. Yes,
You divide out the interfacility versus 911.
I don't yet.
Good.
I don't yet. But you know what? I do account for, because I do my cost per transport and I know what my cost per transport is, I can determine what my cost per transport is for Pikes Peak Regional Hospital. And since we do track not only patient revenue by district resident and non-district resident, I mean, I can actually look into my billing program and see how much is it costing to provide Pikes Peak Regional transports, how much revenue am I receiving, and I'm taking a loss on that, taking a huge loss on that. And I think even when we go into the 225 task force, that's one of the things that we've got to discuss with the 225 task force is a lot of times EMS is relied upon to supplement the funding of the facilities or meeting the mission of the facilities. And part of that problem is with EMS is we can't say no. We can sometimes become our worst enemies because we can't say no. And that's part of the reason why we're in this financial dilemma that we're in today. At the moment, we'll see how my sales tax increase goes through this year. I really can't afford to say no. Because just like I told you at the beginning of the presentation, right now, by doing interfacility transports, that's generating some revenue that would otherwise, the crews would otherwise just be costly. And so on that right now is, even though I think the last time I looked, it was about my cost of providing Pikes Peak Regional transfers was right around $1 million, $1.2 million. The payer mix is so bad, I'm generating about 300,000 revenue out of that. But sooner or later, even as a district, we're going to have to go to Pikes Peak Regional and say, if you want us, or we done, or you done. And if you want us, how much are you going to pay? And we've already started that because we don't do transfers after 10 o'clock at night. Unless they're called what we call a level 1 transfer, which is the equivalent of a 911 call. Or they absolutely can't find anybody else to do that transfer. So we're starting to say no at certain periods of the day. Well, now we'll kind of get into what I call the fun stuff. And even if you think about some of the other presentations that you've heard, we talked about our cost per transport. Why do you really focus on cost per transport as opposed to cost per call? Calls don't pay. Transports do. Don't pay. Pardon me? Well, I didn't necessarily say how well they pay, but they do pay. And so we have to frame a lot of our discussions on cost per transport. And that is a relatively easy calculation to make. You literally do take all of your expenses and you divide them by the total number of transports. And that gives you what your average cost per transport is. But I also take a look at what is my margin. Because what's interesting is they always talk about cost per transport, but they don't talk about revenue per transport. And so when I take a look at my financials once a month, I look at it multiple different ways, which will get a feeling of as I move through this presentation. But I do take a look at, right now I'm generating, it's a little bit early in the year because I haven't spent all my property tax revenue yet. A lot of that comes in March. And then you have April and May where you really don't get anything, but June and July are your next big months for receiving property taxes. And of course, you have to make those property taxes that you receive in just that short period of time last through the rest of the year, all the way through to next March. When you get your next big property check. So even though right now you can say, oh my goodness, you're making $183 per transport, just know that as I go into this month and next month and next month, that number is going to go down. And even when I start my new year in January, that's going to be a relatively low number. Now I show revenue per response because you can see the cost is a lot less. And I mean, even put it into perspective, Sean and I, as we were working through the 225 task force and coming up with the financial response, we discussed this a lot. Once again, the whole purpose of trying to even adapt what we were doing in the 225 task force and trying to explain how bad EMS finance is, there's a big difference between these two numbers. And there's a big difference in the margin between these two numbers. And realizing that cost per transport is what matters, not cost per response. Now you're taking a look at this. I'm certain this side has gotten a lot of attention. That's my paramedic, my community paramedic program. Now you have to start applying the right metric to the right system or to the right program. Because you see that, ooh, that's really expensive. So why do I want to get into community paramedicine if it costs that much? On the other hand, when you take a look at how many responses we've done versus transports and realize this is not our focus, the transports is not the focus of the community paramedic program, that's when we start talking about our UHUs. And even when it's like, I fought UHUs and learning UHUs for most of my life and as an administrator, probably because I really didn't understand them. And I really didn't want to understand them. And I didn't understand how to apply UHU to my service because I was so small. I could see for an AMR or a CSFD or a big business, Eagle County, for example, runs probably 2 to 3 times the calls I run where UHU might be, but it didn't apply to me. A UHU is the 1 hour of availability of a fully staffed ambulance is what it means. And there's a computation and it's really simple, because Excel can do the math for you. All you gotta do is figure out what the formulas need to be. And it all starts off with a period that you're looking with, start date and an end date. So you can calculate the total number of days times the total number of units you have on board, times you can either do this number or this number to come up with 19,584 total unit hours of availability for ambulance services. That's getting down to your UHU. Well, even though I compared my cost per transport to my revenue per transport, now maybe I want to take a look at how much am I spending or making it out. And this is per unit. And you know, it matters only when you need to know it and who you need to talk to. Because as I work through our election this year, because one of the things is when you think about, you can take a look at some of the financials and then you quickly understand that we're a failed economic model. It just doesn't work. And even with Scott Moore's presentation yesterday about the best advice to take everybody to the hospital, is that really practical? Should we really be treating patients with the least expensive service, if you will, still provide them with the best possible patient care at the right place, at the lowest cost? Isn't that what we should be doing? Well, it's interesting because I'll show you that even on my EMS side right now, it's costing us $173 every time that big hand on the clock goes around. Now you take that number, you multiply that times 3, and you start seeing how much it costs per hour for 3 units. You see, at the moment, all my revenue combined, I'm generating $186, so I'm making about $13 an hour. Completely different way of looking at it, but you see my margin is starting to get smaller, and it's a different way of looking at it than my cost revenue per transport. This is something that I think is really noteworthy for my community paramedic program, and that is the metric that we talk about. And even in the election, if I can get away from adding more of this and get to more of this, when it's costing me $173 an hour for an ambulance, but it's only costing me $66 an hour for the community paramedic program, you do the math. Even if I'm not getting a payer source for that right now.
Tim, are you doing that on QuickBooks or is that an Excel upload?
So this is Excel.
That's Excel.
This is not in QuickBooks. This is Excel. Any questions on this?
Where's your actual UHU number there?
So, well, we'll get to that.
Okay,
Ah!
there we go.
And this is for my 911 side. How can it apply to me as a smaller service? How many of you constantly get told by your crews, oh, we're so busy. We're busy all the time. And granted, it's perception, right? Because it's like, depends on the time of year. This number, that UHU may vary, because it'll be higher during the summer generally than it could be in the winter, depending on where you're from. I'm certain that Brandon's UHU in Eagle County stays relatively consistent, and probably Sean's as well, because it's a high tourist area, but it does do that, right? But how do you quantify it's so busy for me? Well, what this tells me is, on average, every ambulance is busy with the response UHU is busy 4.46 or about 4.5 hours every 24-hour period doing something directly related to the business that we provide. That's patient care. 4 hours, 4 hours, 4.5 hours. Is that too busy? When you're hearing it's too busy? This gives you a starting point. And one of the things that I'm excited to do, because I just heard of another metric, but I gotta do a little bit more research to figure out how do I add on this other unknown metric. This just tells me how much time the crews are spending directly related to the business, taking care of patients.
And that's not including documentation, right? That's just.
That doesn't include documentation. It doesn't include the time spent on checking out the ambulance. It doesn't include station chores. It doesn't include any training time that the crews could be doing during the day. It doesn't include, I don't know how many of you, especially in the smaller services, may have extra duties that people perform. You may have one person assigned to coordinating vehicle maintenance. You may have another person assigned to coordinating medical supply.
So how are you picking time on task? Is that just a package?
Pardon me?
How are you picking your time on task?
So that's what I'm working on trying to figure out. But what I like about the UHU is this gives me a starting point. That's what this does. This is the time on task for response for what they do directly related to my business. And I can start adding up, and that's what I want to do, because I found out from Blue7 the fire industry has a calculation to maybe add on top of this that would give me a true picture. So come next year and I'll have that ready for you.
So to Brandon's question, or to Austin's question, right now your time on task is 10:8 to 10:7, basically. 10:7, whatever that would be.
I'm sorry?
That is that tone to.
Yeah,
in
so
service.
time on task is the time that we get the call, I'm sorry, to the time that unit goes back to service.
Is that just an estimate you came up with?
No, I get that from my
That's your
EHR.
Yeah, okay.
I get that from my
And
EHR
responses is volume.
and asking, yeah, total volume. But you also gotta understand, when you're taking a look at that 4.46 hours, that includes responding to calls, refusals, that includes cancels, that includes got on scene, it was a DOA, I didn't do anything, that includes all that other stuff. So then what I gotta figure out is, of that 4.5 hours today, how much time are they actually out there generating potential revenue for the district? Because my crews tease me, it's like, we brought you another check, we brought you another paying patient, we did something to bring you money. May not necessarily be a good payment, but at least we're out there generating revenue. This is, so out of that 4.5 hours, we're spending about, 3 hours and 15 minutes actually generating revenue for the service. Yes, sir.
Where's your base UHU figure coming from?
So the base UHU, again, what you gotta understand is, and I don't look at just a base UHU, because the base UHU is an hour. Now, maybe for you or the services in Colorado Springs where your average total task time is an hour, that applies. This is a great question because I actually almost forgot. For me, though, it doesn't necessarily apply. I have to figure out that on an average response, by the time I get there to the hinterlands of the district, overall, it takes about an hour and a half to run a call. So my base UHU for responses is total hours divided by my total, or my total responses divided by my total hours gives me this base UHU for response. Well, like I said, it's not an hour, so I have to multiply that times an hour and a half to get my modified UHU. I divide that by 20, or multiply that times 24, because it's 24 hours in a day, to get the 4.46. Does that make sense? It's the same thing over here. Since I run fewer transports, I do the same thing. Take the transports, divide it by my hours, gives me my base UHU. My average transport time is 2 hours, gives me this transport UHU of 0.14. Multiply that times 24 hours in a day, I get that 3.34 hours per unit per day. Again, remember, if I have 3 units, that's this number times 3. Yes.
Does the response UHU consider the amount of time to get back into the district that you transport out of the district?
So the only way that I have to calculate that,
Can you repeat the question?
so the question is, does the response UHU equal the time it takes to get back into the district? We don't have a hospital in our district. Well, we do.
Jeez, Will.
We do. But a lot of it's a critical access hospital, and since the hospitals in Colorado Springs are so close, we still transport a lot of our patients down to the Springs and back. Does that include the time that it takes to get back? Maybe. I think some of the crews call in service right when they're leaving the hospital. Some crews will call back when they're at least in the district. So that is something that might help you understand the total task time. Is maybe by policy, we have to clarify that a little bit more, so that at least they're back in district. so they're closer and available for a call, that might become more helpful. And I think even listening to the radio, a lot of the crews do that. And so that time is captured when they're back in service in the district, not necessarily at the station, but in the district. That help? Okay, any other questions on response and transport UHU? Okay. Just another way of looking at it.
Jim,
Yes,
this is kind of off topic and it's only gonna affect 3 of us. Do you UHU for game related calls?
no, but I probably could. I mean, because it's a calculation, all I gotta do is identify those calls. And because we do track each call that might be gaming related, because we also track calls that might be like, I don't know, Karis Bible College related, district, non-district related. You could do that. And the calculation would be the same. You just have to identify your parameters through your EHR of what you're looking at. You could. So another way of looking at it, we're running about 9 calls a day, Little Woods UPass Regional Health Service District. We're transporting about 5 patients a day. But when I start breaking that down, it's 3 responses and 2 transports per day. Why do you need 3 freaking ambulances? Well, we have a large district, number one. So we have 2 ambulances in Woodland Park. We have an ambulance out in Florissant, which is about, 30 miles away. So to improve response times, we have more than 1 station. But the other thing that is really cool to do is, what is your spontaneous call rate? Spontaneous call rate is how many times or what percentage of the time do you have more than 1 ambulance deployed at the same time? 43% of the time we get 1 call, we get another. Just last month, though, look at the difference. It was a 63% concurrent call rate. Why do I have more than 1 ambulance? Since I can't pick and choose my patients, and since I can't schedule them, when it rains, it pours. When it's dry, it's a drought. I have to have more than 1 ambulance is ready to go.
Tim, do you have an easy way to track the simultaneous runs other than just looking at the times of each one?
Do you have ESO?
Yes.
I'll show you a way of getting that. Cool. Because ESO, somebody somewhere out there in the world did a wonderful thing in coming up with a spreadsheet that you can, and Aaron, I have super duper extra special wonderful employees. And one of them is this gal right there with a laser pointer. When it comes to running a lot of the data, she's like, Aaron, quick, financials are due. Get this number ready for me. And she does. It's amazing. But there is in ESO a way for you to determine that. Simply. And even with the PACT, I do the same thing. They're averaging about 3 responses per day. This is the number that I like seeing because that's not the focus of the, and even with our mobile crisis response unit, the goal is to get them the services that they need or the referrals that they need and the safety plan is what they need. And so even if we have a patient in crisis, we do go in, we de-escalate the situation, we engage the patient, exchange behavior, and then we start figuring out what we're going to do with them. And most of the patients we can safely place with referrals. And our program also follows up with those patients to make certain that they met with their referral. So they're actually getting the care they need. Yes, sir.
So if you have in your community paramedic program, you have 1 response per day, and you have 1 unit,
1 response per day per unit.
and how many units do you have?
Oh, no, I'm sorry. This is responses. So, and it's funny now because now that we added the Park County call, we have 3 unit, there are 3 responses per day. We have 1 response per unit.
Okay.
And now that we've added Park County to our system, which we're getting fully funded to provide, by the way, in Park County, that number is going to increase.
And a day is 24 hours?
Day is 24 hours.
So it appear, and I realize Park County is massive.
Yeah.
What are they doing the rest of the time? Is there a crossover between CP and
Yeah,
911?
CPs can definitely start responding to, see, and that's one of the cool things when I think about even the value of the community paramedic program, and even when we start thinking about some of the presentations we heard yesterday about, God, paramedics are expensive, and God, it's hard to find paramedics. And when you can't find paramedics, they become more expensive because you have to send them to paramedic school, you have to pay them to go to paramedic school, you have to help them pay for paramedic school. And even as we start deploying differently, maybe we need more community paramedics and lifeguards than we need paramedic staff and ambulance. So this can become a force multiplier for us. Thank you. As we're working throughout the system. When we talk about funding EMS, what is the big thing we talk about? It isn't the cost of the response that is our big cost, right? It's the cost of readiness. Later on this afternoon, you're going to hear somebody talk about in my election presentation, and he's from New York, and what he'd say, we talk about cost of response, but what we should really be talking about is the cost of readiness, because that's what costs us the most. One of the things that we're not able to do as an industry is quantify what that cost of response means. How much money are we talking about between the difference between the cost for readiness and the cost for transport? Your UHU is the unit of measure to help you determine that, because that's the time of an available ambulance on a transport. So you use your transport UHU, and you can come up that 16% of the time the ambulances are doing something related to the business. You can take the direct cost from your cost for transport. Now, what I do is a little bit different, because you see this cost for transport went up because I'm funding my entire organization, the 911 side and the PAC side, off of my current revenues right now. So all of my revenues divided by my total transports now gets me this. So my direct cost on an average cost per transport, $3,186, is $499. That's the cost directly associated with providing services to patients. That's the cost for transport of readiness. It's 84% of the cost. So if somebody asked me what the difference is, and when you talk about cost of readiness, even to my taxpayers, what does that mean? How much money are you talking about? I can say of my total budget, that's the difference. Right there. Sir.
So, and maybe I missed the connection. Why would you use specifically transports for readiness versus time on incident?
Because once again, even when I'm thinking about and trying to be consistent in most of the stuff I'm talking about, calls don't pay,
Right.
transports do.
Okay.
So when I'm trying to figure out of my revenue, my cost, and I'm trying to tie that back into my revenue sources, I'm trying to be consistent with cost, and
Okay.
and it even makes it higher, right? So even my cost for transport or cost per response is going to be higher. So even if I want to err on the side of being high on each one of my calculations,
It puts it there.
when I'm doing that, it's still a tiny number. It's still only $499 versus $2,687, or $3,842, or $3,842,430 is my cost of readiness. Now, can you imagine if we went to the legislature with anything in the future regarding what we're trying to advocate for the fix for EMS in Colorado? And if we could add all these up and we could quantify that number, how powerful that number would be?
As long as we're all cooking with the same recipe. So I can calculate it right in this thing. Tim is, or Sean is,
And I think that that is exactly part of the problem. We don't all operate off the same standard, the same accounting standard. We don't talk the same language back and forth from each other. But you know, even if he runs 10 ambulances, you run 6 ambulances, and I run 3, we can still do this basic math based on our individual systems for the accumulation of the bigger picture. My board loves to know, and even my taxpayers like to know, where's your primary sources of revenue? How does that break down? Well, 56% of my revenue is from taxes. If I didn't have that, I'd be screwed. 28% or roughly 30% is my patient billing. And the rest is grants or other revenue or contracts with the VHA, especially for the mobile crisis response. And it's funny, because even when I think about mobile crisis response, a lot of people ask, well, how are you funding that? I gotta give kudos to this gentleman right there. I'll laser point him. James McLaughlin and Aaron. We kind of got it on the ground floor of a lot of the mobile crisis response stuff and the mental health response stuff. So even when we went into with the VHA and our local, well, it wasn't the VHA back then, but it was our local behavioral health. What do you call them?
They're the crisis stabilization.
So
CSU.
that group that runs the crisis stabilization, because the state allocates money to each one of the regions, we were smart enough, I can't say this because of, Tim is the bright one in the room, he was, got us into those discussions along with CSFD. And so we were on the base floor of getting money specifically for our program to be able to provide that telecounting. And I can tell you, it's even so funny when you think about community integrated healthy community paramedic. I remember the one person that we started with, we just knew for certain she didn't like us. We just knew for certain she didn't think that paramedics could do this kind of work. And we knew for certain she was trying to undermine our system and the money that we were trying to get out of it. But the relationship grew, and we showed that we can do it. We can do it effectively, efficiently, and safely. And that we were the answer to a lot of rural health. Now, sometimes it's funny because if they have extra money, she's like, could you use another $50,000 for something?
All the time.
Here you go. And so a lot of this stuff that you're talking about funding it's a matter of relationships and relationship building. And that's where we're getting a lot of our money for that. But even then I break it down, not only just in general from my revenue sources, but now how do I compare that? So 56% of my revenue sources pay 59% or 60% of my expenses. Once again, that tells me, I didn't have that for screwed. Ken.
On your tax revenue, you do have a plan in place for those who live in the district. Is a scholarship, how does this work?
So we do. Then let me cover that in my next presentation.
Okay,
Because that's elections, right?
all right, very
And
good.
that kind of goes directly into that presentation. Well, I'll tell you what it is. Is we have the non-district resident no balance billing program because the Office of the Inspector General has said that the taxpayers' continued obligation to pay taxes to your district can be considered in lieu of payment of co-payments and deductibles. So even one of the things that's a huge selling point when we're going for our tax increases is we don't do balance billing for you. Because you have your continued obligation to pay taxes to us. So that is a huge benefit.
But if I drive through your district, you're gonna balance bill, but you.
Like nobody's business.
That's what I thought.
Like nobody, but even, it's funny, even from a billing perspective, and I don't know what the rest of your experience is, but I can tell you that our experience with getting payments on deductibles and co-insurance, patients want to go back to the hospital just in case they have to, because they've been there once, and even though you could say the same thing with the ambulance, you use this time, for your heart attack, you might need us again. They definitely want to be able to go back to the hospital, not necessarily the ER, but everywhere else they may go, because that's on the system. You don't pay them, you don't get to go back. And they like to pay their physicians and all the doctors that take care of them, because physicians, maybe not in the ER, but everywhere else in the hospital can say, you know, you still owe us money, so as soon as you at least catch up a little bit, we're not gonna see you. We're not that way. And kind of lost my train of thought there, but we have a terrible time collecting our, we send most of those payments to collections anymore, minus the district residents, but they still show up as write-offs. So why fight that battle? Especially if you're a public entity, why fight? Because it's very small, even when you take a look at, I could probably go back, let me go back, just so you can see from a standpoint of my expenses. I think my collection revenues probably, oh. My collection, oh, I'm going backwards, not forwards. My collection agency revenues, we send about 400,000 a year. Sorry. Why am I fighting that?
Not worth the money.
Pardon me?
Not worth the expense.
No, it's not. And you know, what's interesting is everybody says, well, did you do the state collection agency? You know, because for a while, if you were a public entity, you could have the state actually do the collections. And one of the things that we thought, you're gonna get a letter from that has the state logo on the top of it that says, oh, by the way, you owe. That didn't work, because I found out that the most organized, but really disorganized system in the state of Colorado was their own collection agency. And we've gone to several other collection agencies, and I mean, it isn't because of a lack of trying different collection agencies, but we don't make any money off of it, so why fight it?
How many hours of work are you putting in the city?
Pardon? Yeah. And then it's funny when you really look and you really evaluate, I think there are some problems, even with our current billing system, we're gonna be doing an RFP for a new billing service real soon. We might be holding on to claims too long. I mean, our billing service in the past is, well, let me hold on to that for that comment. Because what I want to go into is, this is our payer mix. And this is probably part of the reason why we need a tax subsidy, is that 77% of the patients we take care of or transport to the hospital, Medicare, Medicaid, and the uninsured. And even from a standpoint of really knowing this number and being able to explain it, even when we formed the district, I was trying to get a letter of support from AMR, it was Ted Sains at the time, to support us. Pardon? 5 minutes. Okay, 5 minutes. Trying to get him to support us forming the district. It's like, fine, want to come up? Here's my payer mix. And by the way, World Ambulance won't do it. If you don't want it, come up. And I was able to get his letter of support for forming our district. And that's kind of my trends. When you see my biggest payer, we've been swapping back and forth with Medicaid. I never thought I'd say though, bring me more Medicaid. Because you add the SRP payment in this and the payment gets a lot better. Now this is probably the most, I'm getting towards the end, probably the most controversial of my entire slide. I know that in several years we've asked people like Isabel and we asked Matt Zavadsky. I mean, for most ambulance administrators, it's like, how do you determine how much you're going to charge for that muffler every time you go out the door? Because the last thing I want is to have Channel 5 News, because 5 wants to know when somebody complains about an ambulance bill, especially somebody from Colorado Springs who gets balance billed because the insurance didn't pay enough and they're getting stuck with the bill. I could look them in the face and I can say, I didn't make this up. I actually have, and this comes from that book. It's way back in the appendices. How much you charge is a function of your cost for transport and your collection percentage. Because that's one cost, and even with Scott Moore, we discussed this formula, and he'd say, there's one cost you haven't accounted for, and I keep saying I have, and that cost is the cost of uncompensated care. That number, that comes in right there with that 29%. It's funny because since I'm a tax supported entity, I do take my total expenses divided by my transports to come up with my cost per transport. Since I'm a tax funded entity, some of that cost is prepaid because my taxpayers pay it. So I literally take all of my revenue for my taxes and of course with my grants, divide that times my transport, and I come up with a revised cost per transport, which is $765. Well, 77%, 72% of the payers I have aren't gonna pay that. So I take advantage of my cost of uncompensated care, and that's what my average bill should be. Now, how I break that out between base rate and mileage is a matter of Teresa to figure out, but that's how much my average bill going out the door is. You have to at least charge your costs. All right, well, how's that for timing?
That's a mistake.
Katie should see that as a familiar picture, but any questions? I hope it was valuable. I hope.
I want to stop sharing now, right?
Okay, yep.
No, I'm asking.
Oh, you can, yeah.
Believe me, when it's.
That's
stuff,
my
I don't
contact
remember.
information. If you want more, I have the whole, I did share it with you, but I saw a couple of errors in it.
Me too.
But yeah, no, cool. But I do have it's a whole document that I give to my board every month.
It's an awesome presentation, Tim, and I agree with you. We should decide as a community on similar values, so when you go to the state, it presents a very powerful picture of the total failure that we are facing.
That's a lot. It's a lot. And we have no idea what a lot means. So even if we're talking about, we can model the data. Sean and I
Are
have
you
done
doing that later?
a lot of that. Pardon me?
Are you doing that in your sustainability?
Yeah, I'm not. But I think that's something that maybe, I'm gonna do a little bit of group presentation on 225. Thank you.
So, thank you. I love this stuff, obviously. The question I have is when we talk about, especially if you're a tax-based entity, being the value option in a community, have you looked at any way to capture cost of being the value option as far as, what is your downstream cost savings based on your additional programs? And then in a less self-serving manner, what about cost of increasing client satisfaction? Do you know of any way to formulate that?
So first of all, let's refer back to some of the presentations yesterday. Patient satisfaction and scores, I think we really need to, as an industry, and we don't, and we should. But I want to be careful of cost creep right now, because that's another thing that we're going to be paying for. It's an unreimbursable expense, right? So I want to be consistent with what I just talked about. But Tiny, why don't you give them a brief idea of what we're looking at right now, especially as far as the community paramedic program goes?
Well,
Answer your question.
Well, and I would tell you, the client satisfaction piece is the one that I actually really interested in, because I don't know a way, and I don't know if there's a quantifiable way to truly track. If I want to increase my client satisfaction overall globally by 0.1%, what does that cost? And that would be a really cool formula to generate, because then I would know, hey, if I apply it, and there's obviously always variables, because in economics, it's all things being equal, and there's no way you can do all things being equal in this process.
Right.
But if anybody knows of a formula to track that, I would love to hear an idea, because I think that's really valuable when you talk about increasing value in the community. Put a pin in that, go back to the other piece. What we are doing is our board asked us to start reporting approximated cost savings based on all of our mobile integrated healthcare services, our behavioral health programs, stuff like that. And Aaron actually designed a tool. We reached out to the various hospital systems and we said, what is the cost of this kind of patient coming into your facility and being seen on average? And they gave us a global cost of that. And we know what our average, because Tim has done such a great job, we know what our actual cost of transporting is. And we take those two pieces of information, we put it together, and we identify patients that would have traditionally been transported that are no longer being transported. They're actually being treated in the community, set up with resources, and then being upstream navigated to the more appropriate downstream resources. And then we take that per incident or per occurrence and then apply it to that cost. And what we're able, and it's really rough right now, it needs a lot more work, but Aaron, if you want to talk about those numbers, if you
Or just give us an idea of where we are right now.
Yeah,
Yeah, she does.
but she actually created an amazing tool that gives us near real-time dashboard data on day by day how much downstream cost we're saving.
And what's interesting is that as we work advocacy in the future, because I could tell you even one of the things that frustrated me about Scott Moore's presentation yesterday about the safest thing to always do is take the patient to the hospital in an ambulance. And we know that's not practical, is that we know that there's treatment in place, legislation pending at the state level. We're talking about doing a treatment in place legislation in the state. We also know that there is mobile integrated health legislation pending at the national level. So there could be hope in the future. And I'm certain that Brandon already knows because he probably got the email from the attorney who happens to be with the same law firm as us. We're going to be collaborating on data between us, Eagle County, and Delta County to show to him healthcare policy and finance of what we can do, what we can potentially save the system. So that's it, Tim, right?
Yes.
I'm out of time. Sorry, folks online. Sorry, folks in the room. No more questions.
He's like a superstar.
So I'm going to actually stop the recording.